In this episode of the ASC Podcast with John Goehle, we cover the latest updates from the ASC industry, discuss recent survey experiences, including a discussion of proper vaccine storage, and in our focus segment, we discuss governance and the governing body.
Welcome to the ASC Podcast with John Goehle, the longest-running podcast specifically focused on the freestanding ambulatory surgery industry. We would like to thank our sponsors, Surgical Information Systems, providing cutting-edge information solutions for surgery providers, RFX Solutions, your all-in-one healthcare regulatory compliance software, MedServe, which is the only digital narcotic cabinet specifically designed and priced for surgery centers, helping standardize processes, compliance, eliminate paper logs, and prevent drug diversion, and Ambulatory Healthcare Strategies, the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For more information about our sponsors, please visit our website at ascpodcast.com.
Welcome to episode 241 of the ASC Podcast with John Goehle, recorded on April 14th, 2025 from our studios in Spencerport, New York. I'm Sue Cronkite, your co-host and operations manager at Ambulatory Healthcare Strategies. As a reminder, the regulatory landscape for ASCs is constantly changing. The content in this episode reflects the most current information available at the time of recording. We encourage all ASCs to remain vigilant and keep up with any updates or new guidelines released by relevant regulatory authorities. Joining me today is John Goehle, owner of Ambulatory Healthcare Strategies and one of the leading experts in the ambulatory surgery field. With over 3 decades of experience, John has authored more than 10 books on the ASC industry and is a highly regarded speaker on topics related to regulation, accreditation, and finance management.
So, Sue, this is like deja vu. We already recorded this episode, and then you went to edit it, and
Yes.
what happened?
Well, my mic was off the entire time, so we take this as a lesson.
Right.
We should do timeouts.
Right.
We should do checklists. We need to follow our own advice.
That's right. So we now have a checklist that we use before we record, and as Sue said, we're going to do a timeout just to make sure all of our microphones are working and everything is working. It was the way I look at it, though, is that the first time with Sue was a rehearsal. So now we're into the live show here.
Yeah.
So sadly, Rosie's puppies, you might remember we've talked about Rosie's 9 puppies, which were born on Super Bowl Sunday, have all gone to their forever homes. And all 9 of them have found wonderful puppy parents. We're so proud of those puppy parents. And we're getting pictures constantly about how well they're doing. So, so poor Sue and myself and Rosie are all kind of sad. Well, maybe Rosie more than we are, since we always had to clean up after them. But it's great. For those of you that are somewhat new to the podcast, Rosie is our English cream golden retriever who's kind of grown up on the podcast. She appeared in many of the conferences over the years that we've done here, and she's become a fixture. Yeah. And people always comment about her when we meet them or run into them at conferences. So Rosie is retiring from momhood after this or having puppies after this, and more to come about a possible puppy in our future to continue on in that tradition.
And the puppies have made many appearances too on
That's right.
Conferences and things.
They show up in
cute
in presentations. We do want to congratulate 2 of the Ambulatory Healthcare Strategies clients who opened within the last couple months. The Empire Center for Special Surgery in Staten Island. That is the first ambulatory surgery center in Staten Island, and our good friends Gabe Figueroa and Jeffrey Flynn opened that center, and they just had the grand opening last week. So if you have an opportunity to be in that area, you definitely want to stop in and see that new center. And also, congratulations to Northtown's Ambulatory Surgery Center in Buffalo, New York. They've gotten quite a bit of publicity recently, haven't they, Sue, over a certain robotic surgery system?
Yep, it's the first distal motion Dexter robotic surgery system in an ASC, which marks really a major milestone in expanding access to robotic surgery by addressing existing barriers to surgical robotics and outpatient care. So it's an exciting new step.
Yeah, and I'm going to pronounce this name wrong, but Dr. Stephen Schweitzberg, noted that the ability to set up a robotics program in our outpatient facility without disrupting existing workflows is a game changer. And he is a general surgeon over at Northtown, and he's also a SUNY, State University of New York, distinguished service professor and chairman of the Department of Surgery at the University of Buffalo, Jacobs School of Medicine and Biomedical Sciences. And he indicated the device will help the ASC to improve the workflows and deliver minimally invasive care with less cost and improved precision. And this is according to a news release that they have. Now, Dexter is a soft tissue surgical robot that is compatible with current surgical technology and adaptable to future advancements. Now, the reason we brought this up is that, what was it? Not even 5 years ago, a robot in a surgery center was both extraordinarily costly and very unusual, of course. And now we're starting to see them popping up quite a bit as we see these procedures being moved out of the hospital setting into the ASC setting. So more to come on this, I think, as we progress here, where, certainly there's been a massive movement of procedures out of the hospital into the surgery center, especially post-pandemic, as the hospitals have had to deal with much more complex situations, and surgery centers can take care of patients, that even have what we would consider major surgery. So, as usual, I do check the CMS website periodically to see if there's any quality, safety, and oversight memos, and there are none. Again, I think the last time we saw one was I think it was November. That affects surgery centers. I don't think it's going to continue like that. I do think that we're going to see some movement over the next year or so in that area. But to that end, Sue, you're working on the research for the survey guide, a guide to the ASC conditions for coverage and interpreted guidelines. I know you and Amy have been working hard at putting that together. Hopefully we'll have that published within the next month or so. More to come on that also. So, Sue, we have some news, don't we?
We do. So I had kind of jokingly at the beginning of this said that, we need to do a timeout. We need to really slow down and pay attention to what we're doing so we don't have to repeat a podcast that we, accidentally didn't record correctly. But I've got a couple of articles that really show what can really happen, a couple of really frightening stories. So in the New York Post, they reported on a patient who was burned while undergoing a tracheostomy as part of his treatment for cancer on his tongue. He was in an Oregon hospital, and the staff sterilized his face to prepare for the surgery, but they didn't let the alcohol fully dry. And so when they started the surgical tool, it ignited. And, of course, combined with the oxygen, it started a fire that burned his face pretty severely. Now, he was even awake during the fire and conscious. So his family is suing the hospital for $900,000. The patient actually died from the cancer 6 months later, but those last 6 months, he had to endure that extra pain, the swelling, the scarring that had come from having that fire from that mistake. So the Emergency Care Research Institute estimates there are 90 to 100 surgical fires in the U.S. each year. And they have to estimate it because they don't always hear about the ones that happen. But again, it's such a simple thing. But I think when you do these things day after day and nothing goes wrong and you just get used to it, you can really become lax in it. And just remember that, some really bad things can happen if you just rush through something and, don't take the time to really check everything, make sure you're being patient with letting things dry, all those things that you might take for granted. It's very important.
Well, and it's important to know, even though this situation occurred in a hospital, it occurred in a surgical environment, which is very much the same. It is the same as what we experience. And, so I was thinking about this when I read your write-up on this, that During timeouts now in the surgery center, to your point about timeouts, I don't often hear people talk about the fire risk assessment. In other words, the availability of oxygen, an ignition source, and something like alcohol, which can cause the fire. And I think that this is a good example of why we have to do those timeouts in the center. I can't tell you the number of events over the years that I've seen with serious outcomes, negative outcomes, as a result of not doing a good timeout. And this is another good example of that.
Yeah. So also in Oregon, a jury awarded $20 million to a former professional soccer player after he suffered complications from a leg surgery. So he was diagnosed with bilateral stress fractures back in 2018, and he had surgery to implant metal plates in both shins. After the patient was sedated, the surgery team realized that they didn't have the correct plate for the right leg. So rather than waking the patient up and rescheduling the surgery, they did flash sterilization or immediate use steam sterilization, whichever you'd want to call it, same thing, on an implant so they could complete the surgery. The patient later had signs of infection in his right leg, and he had a washout surgery, even though one of the original surgeon's partners suggested the implant should be removed as it could be the source of infection. The original surgeon didn't mention the method of sterilization to the patient or to the surgeon who was doing the washout. Possibly they could have had a better outcome if he had just been open about it at that time. So the surgeons said he had never mentioned it as he didn't feel it was relevant to the outcome. And he did say he'd never used flash sterilization for an implant before, as you really never should. Eventually, the patient had a total of 14 surgeries, and he continues to have pain in his leg, so he could, he's no longer able to be a soccer player. He was eventually told about the sterilization issues when one of the surgeon's partners broke down and told him that he'd been implanted with a dirty plate. So, then this all kind of came out. And again, just talking about implants and equipment during the timeout would have avoided all this. And the second thing would have been, just if a mistake is made, don't worry about the embarrassment. Don't worry, the patient may not be happy about being woken up. But, he just should have made sure everything was done right, even though, he felt, it would be. I think the biological testing came back looking good and everything, but it's just not standard of care, and he really just shouldn't have done that. And then he should have, the third thing, should have been open about it,
right?
And they could have possibly prevented some of this.
I could go on for hours about what was wrong here, and I hope that the center did a good root cause analysis to figure out how many points of failure occurred here. First of all, nobody should be doing immediate use steam sterilization except in the most dire of circumstances. Here, they had a choice. This was not an emergency. The only time you should be doing IUSS really is when you have an emergency.
Yeah, especially for an implant.
Especially for an implant, right?
They're so prone to.
And I still run into this, I've been in the industry for, well over 30 years, and I hate to admit this, but back in the 90s, we were doing eye surgery, and I got to say, back in those days, it was not uncommon for surgery centers to be doing flash sterilization on those eye instruments between cases. And I think we were just lucky that we didn't have really bad outcomes, but that is no longer at all the standard of care. It really wasn't the standard of care then. It's no longer appropriate at all. And this is another good example, Sue, of how important it is to report through the Quality Improvement Committee anytime that you actually do immediate use steam sterilization, IUSS. So that the governing body is well aware of when it happens, what they could do to avoid that in the future, et cetera. Now, in my career, I've seen times when, you've had to do it because you were 3/4 of the way through the procedure. The patient was still under anesthesia, deep under anesthesia, and somebody dropped an instrument or it became contaminated. And we get it, But again, the doctor needs to make a decision at that point. Is it worth the risk of doing IUSS given the situation and the timing? There is no excuse for that in this situation.
Yeah, and then follow up. Make sure you see something, go, okay, we know so let's quickly, be really aggressive about the treatment. And I think probably nobody listening would use flash sterilization on an implant, but it's just, again, to point out that things happen. And if you
Yeah.
don't stick to those basic safety things, the checklists, the timeouts, something, can go wrong that could have been avoided just by these simple things that might seem mundane and, tedious, but
Right.
they're there for a reason.
And then I guess you saw an article about sleep deprivation. Nurses having sleep deprivation? That's
know.
never
Who would have
occurred.
thought? So an OR manager from March 13th, they reported on a study published in Chronobiology International looking at the effect of sleep deprivation on nurses' immune systems and how that relates to their risk of infection. The study looked at data from more than 1,300 Norwegian nurses. They found that missing up to 2 hours of needed sleep resulted in a 33% higher risk of catching a cold. The risk doubled when the nurses were missing more than 2 hours of sleep per night. And they didn't give the exact hours. I think everybody needs different amounts of sleep, but this is just kind of a guideline to get the amount of sleep that you need. Now, bronchitis and pneumonia rates were also increased based on the amount of sleep deprivation, just to a lower rate. And it was interesting. They found that working night shifts were associated with higher rates of the common cold, but not with the more serious infections, like the bronchitis and pneumonia. And they also looked at some GI infections, and all of those things increased somewhat. And I have seen other studies, I just wanted to point this out, that show both too little sleep or too much sleep increases infection risk, and consequently, they've done different studies, whether it's, more frequent doctor visits, more frequent antibiotic use. So that really could point to sleep duration being more of a symptom of other issues that might suppress the immune response, such as if you're stressed, depressed, you're exhausted, then your sleep is suffering, but so is your immune system in some other ways. And they really haven't pinned that down. But the real takeaway here, I guess, is how important it is to take care of yourself, especially I think for people in healthcare. You're taking care of other people. You're exposed to a lot of infection risk. And, you have to really take that time to make sure you're doing what you can to keep yourself healthy.
And I think this is particularly notable because I think we are pushing our nursing staff, to the limits right now.
Yeah.
We're short-staffed in many parts of the country. It's tough to get staff, and then when people leave, the remaining staff have to, do double work. So definitely something to keep an eye on to make sure your people get enough sleep. I don't know if there's any way to control getting too much sleep, but I think the takeaway is making sure they get plenty of sleep.
And I think the culture in healthcare sometimes is just go, 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 be the strong person. At least after COVID, it changed that you don't go trudging into work if you're deathly ill. If you've got a terrible cough, if you've got a fever, you're going to stay home now, whereas it didn't used to be the case always. But still in other instances, the staying late, and sometimes you just have to. But
it shouldn't be a regular thing. Just has to be
awareness on this, I think.
Yeah. Let's talk about some recent experiences or discussions we've had. And some of these come out of our weekly drop-in sessions, actually. We always get a lot of great feedback from our listeners during those sessions. The first thing I want to talk about is vaccine storage. First of all, I just have to say, Sue, after reading the requirements, you and I spent some time this last week looking into the requirements for vaccine storage, how to properly store it. I'm just going to tell our clients, don't do this. You know what I mean?
Yeah. It's so easy to get. I mean, if you're just keeping it because you're giving, flu shots to your staff, they can walk into any drugstore and get it, and it just really could save you on the training requirements and the storage requirements, all of that.
Right, and the expensive equipment that really the CDC is expecting you to purchase. So, again, some of our listeners have had vaccine storage citations, which also have been talked about how important it is to educate your staff on the administration of vaccines. But let's focus on the refrigeration because that's where the actual citations have occurred. So the refrigeration requirements for vaccine storage are based upon some general standards recommended by the CDC. And the CDC recommends purpose-built refrigeration units. These would be units that are specifically designed for vaccine storage, and they offer stable temperatures and better airflow than household units. In other words, the variation in their temperature is going to be very limited, within a very small margin. And of course, these units are going to have very complex or very well-designed reporting mechanisms. For example, maybe a computer output that you can print a graph of the temperatures, as well as notifications, sometimes to your cell phones, when the vaccines in the refrigerator are outside of the required temperature range. Now, the CDC does say that they suggest that you could use household grade units. Now, what they mean by household grade units, the only way that CDC thinks that it's appropriate to use them is if the refrigerator and freezer compartments are separate with individual doors. And also making sure the temperatures are monitored closely and meet the standards from the CDC.
Mm-hmm. So not those dorm style or bar style units with that single exterior door where you just open the little inside thing to get into the freezer. That's not appropriate.
Right. Like what we used to have in college. We have one for our drinks, downstairs. Yeah. Again, there's a freezer portion that we never use and a refrigerator portion. And I've noticed, too, that the temperature in that varies dramatically. Sometimes they get cold water and sometimes not so cold. Yes. And that's definitely something you don't want to have happen with your vaccine. So stay away from those dorm style or bar style units. And again, I see this a lot. And you mentioned in our original recording that we also, when you're using the regular household grade units, make sure that you're not storing the vaccine on the door. On the door.
And they had a little graphic in the CDC toolkit, which we'll share the link to in a minute, where they showed that it can help to regulate the temperature. If you kind of put water bottles on the door, water bottles on the top and bottom shelves, which also will help you to avoid somebody accidentally putting it on the door. But I think it just kind of gives that extra buffer.
Yeah. So the CDC recommends also a digital data logger to monitor the temperature and suggests that you keep the data for 3 years or longer as required, that you have an extra monitor in case that one monitor fails, and the device should have calibration testing done every 2 to 3 years or as suggested by the manufacturer's instructions. And indeed, one of the AAHC conditions or the accreditation standards is to verify that calibration is being done on according to the manufacturer's instructions. Also, you want to post a sign that says do not unplug the refrigerator at the outlets. And we really do recommend that you plug those units into a generator or a UPS-backed system. And also to label the fuses and the breakers. By the way, I don't think it's just for these. I think you should be labeling your fuses and breakers for every place in the surgery center. And the CDC does have a toolkit that you can use to make sure you follow the CDC recommendations, and we'll provide a link to it. And so this is an interesting topic. During a recent drop-in session, we discussed if a physician's assistant, a PA, can perform a procedure in an ASC without the surgeon present or with the surgeon not performing the bulk of the procedure. In other words, the PA actually performing most of the procedure with the physician kind of standing in the background or assisting in the procedure, kind of the opposite of what you would expect.
Yeah.
And I got to admit, I had never heard of this before, and the other surveyors that were on that call had never heard of it before also. So I had to look up. I actually had to go back to the condition for coverage, and as everybody knows, I practically have them memorized. But I had to go back to the condition for coverage just to make sure that I hadn't missed something here. And we go back to 416.42 from the conditions for coverage for ambulatory surgery centers, which is for surgical services. And this is what it states. Surgical procedures must be performed in a safe manner by qualified physicians who have been granted clinical privileges by the governing body of the ASC in accordance with approved policies and procedures of the ASC. I don't see that there's any wiggle room, right?
Yeah.
I mean, we talked about this quite a bit. There's no wiggle room here. A PA cannot perform the procedure. Now, they can assist in the procedure as long as, again, they've been granted privileges to assist in that. But the privileges as part of the application for privileges have to be very specific, both for the PA and the supervising physician. So the PA should have privileges that say that they can perform specific portions of the procedure under the direct supervision of the surgeon, and the surgeon should have privileges to supervise a PA performing those particular portions of the procedure. So a PA cannot work on his own, and his privileges and the privileges of the supervising physician must reflect that relationship. We could talk about this for hours, but that's a pretty straightforward condition for coverage there. So I doubt very many of you, I hope this was a very unusual situation that was brought up. And by the way, I think as I understood it from the administrator, they didn't know what was going on until they went into the operating room and actually witnessed it. Yeah. So, you might think that, as an administrator, you grant these privileges, you fill out the paperwork. Until you actually go in and witness what's going on, you might not actually be aware of what's happening. Maybe your staff doesn't know what should be happening in the operating room. I don't know where things broke down, but it's important that you, as the administrative director of nursing, really do pop in periodically to look and see what's going on. Yeah. So as we go into our focus segment, I just want to kind of remind everybody that the governing body in an ASC has significant responsibility for the oversight of the center. And we've talked about the governing body in a couple recent episodes. I think in December we talked about, what you should do on the annual governing body meeting. But we really haven't delved into it quite deeply since 2023. So we thought we would go deep into this during this episode. Let's take a short break, and when we come back, we'll talk about governing body. It's been a long day, and the surveyor's just left, and you are exhausted. And looking at the list of items that you have to address, you wonder, how can I deal with this and still take care of my patients? More importantly, you wonder, how can I ever keep up with all of the regulations, standards, and accreditation requirements? How can I always be prepared for a survey and reduce my stress levels? Well, that's what Ambulatory Healthcare Strategies does, day in, day out. We become your outsourced regulatory and accreditation resource. We can maintain your policy manual, develop your education programs, help out with fire and disaster drills, do your risk assessments, oversee your quality improvement activities, help run your quality improvement meetings and governing body meetings, and we can even prepare your monthly or quarterly financial statements and help you figure out where you are financially. We are a retainer-based service. We don't take ownership. We don't charge based on your revenue. We have one fixed monthly fee, and we can tailor your services to your exact needs. So whether you're looking for help getting over a survey, preparing for a survey, or looking for a long-term relationship to assist you with your ongoing regulatory and/or financial needs, please give us a call at 585-594-1167 or email us at info@ahstrategies.com. That is info@ah-strategies.com, or visit our website at ah-strategies.com. So as we always do when we're focusing on a particular regulatory requirement, we always go back to the conditions for coverage. And I don't know if this is a first-time listener, you might not be familiar with the conditions for coverage, but the conditions for coverage are the Medicare or the CMS regulations that govern how an ambulatory surgery center maintains its Medicare certification. And the applicable condition for coverage for governance and the governing body responsibilities is 416.41, governing body and management. Sue, do you want to read the actual condition?
The ASC must have a governing body that assumes full legal responsibility for determining, implementing, and monitoring policies governing the ASC's total operation. The governing body has oversight and accountability for the quality assessment and performance improvement program, ensures that the facility policies and programs are administered so as to provide quality health care in a safe environment, and develops and maintains a disaster preparedness plan.
So one of the first things that we have to think about when we're talking about the governing body and the management is who is the governing body. So to understand or to see what has been defined in your organization as the governing body, you want to start with the operating agreement. For example, if you're a limited liability company, as most ambulatory surgery centers today are, or your shareholder agreement if you're one of those older subchapter S style corporations. And you want to read through this document regularly because it does outline the entire relationship between the owners of the surgery center, as well as how they've elected to manage that surgery center, manage their relationship between each other. So you want to So you do want to read through that periodically. Make sure that any elections that are required as part of the operating agreement are done and documented appropriately in the minutes of the governing body, and carry out any other duties that are outlined in there. For example, I've seen over the years that sometimes the operating agreement actually specifies when the annual meeting will be. I once saw, in one situation, a bylaw that said that they had to meet on the first Monday of every year, which they had never done, and that ended up with a citation that could have been avoided if they didn't include that. That's a little too restrictive, for example.
Yeah. And sometimes when we take over surgery centers, the leadership, the administrator, the nurse manager may not even know who all the members of the governing body are. And, they, as it said in that condition for coverage, all roads kind of lead to the governing body, that they are ultimately responsible for everything. So it's so important that you know, and that the governing body itself knows all of their responsibilities, because they have to, kind of answer for everything.
That's right. And they're legally responsible. So if they're not understanding that they are in charge of that surgery center, they have ultimate responsibility. They could end up with, legal troubles that they were not aware of. Now, by the way, if you have a sole owner surgery center, then that owner is going to be the governing body. Unless, I guess there could be a situation in which the operating agreement or the shareholder agreement says otherwise. You might have a sole owner situation where your operating agreement or shareholder agreement includes a community member. I've seen that before too. But you, as the administrator, director of nursing, make sure you know what that operating agreement says and that you follow through with it. Now let's move on to the interpreted guidelines for 416.41. The ASC, and it goes on to be a little more specific here. The ASC must have a designated governing body that exercises oversight for all ASC activities. And the governing body, as we mentioned in the condition, is responsible for establishing the ASC's policies, for making sure that those policies are implemented, and monitoring internal compliance with the ASC's policies, as well as assessing those policies periodically to determine whether they need revision. Policy, Sue, is such an important. I know this is one of those areas that you have a love-hate relationship with. I know you, over years, spent quite a bit of time revising policies and procedures, and it is one of the most frustrating things when we're interfacing with one of our clients, because they're trying to run a surgery center at the same time they're trying to keep that policy manual up to date. And so frequently, as a surveyor, I go in and find the policy manual just is not known. Sometimes the employees don't even know where it is, certainly haven't read it, and certainly don't follow through on what it says that they should be doing. Now, note how the regulation particularly stresses the responsibility of the governing body for the direct oversight of the ASC's Quality Assessment and Performance Improvement Program. We refer to that as QAPI. The quality of the ASC's healthcare services, the safety of the ASC's environment, and the development and maintenance of the disaster preparedness program. Now, you might be curious as to why it's so specific about disaster preparedness, and that really comes out of major storms that occurred in the United States over the last 10 years that resulted in significant problems for healthcare organizations, such that CMS decided that they needed to really build strong emergency preparedness programs in all of the healthcare providers, including surgery centers. Now, although the governing body may delegate day-to-day operational responsibilities to administrative, medical, or other personnel, such as the director of nursing, the administrator, the ASC's governing body retains the ultimate responsibility for the overall operations of the ASC and the quality of the services. And since we can't see the activities, as a surveyor, I don't see the actual activities of the governing body during a survey, we have to go back to the minutes. So when you're looking at your minutes, you need to make sure that they reflect all of the responsibilities that they've taken on, all of the things that are included in the conditions for coverage and interpreted guidelines, and including making sure that delegations of the governing body authority to other individuals, such as administrators and directors of nursing, are clearly documented in writing. And by the way, update that every year. I know you might have approved your administrator, 20 years ago, but you'll never remember at what meeting you did that. So you're going to want to go back and repeat that every year just to make sure that it's always up to date. And
as a nurse, it's always been drilled into my head, if it's not documented, it's not done.
Right.
But I don't know that doctors learn that, or
Right. Yeah.
other professions necessarily. So you really have to be sure that they're understanding that. You can't just say you've done something. You have to
Right.
be able to pull those minutes out and show what you've done.
So one thing that I've always stressed to our clients, and we've stressed on the podcast, and we've stressed in our educational programs, is that the governing body minutes have to be quite long. If you were to look at our governing body minutes, they tend to be, what is it, Sue, about 4 pages long, and then maybe 20 to 40 pages of attachments, depending upon what's being reviewed at the time. But, a good 4 pages. You don't want bullet points. You've got to actually show in the minutes the actions the governing body has taken based upon the results of the operations, the results of the quality improvement program, and make sure that there's quite a bit of detail. For example, over the years, I've seen minutes as I've done surveys that have said all of the providers have been recredentialed. Well, that doesn't mean anything. It doesn't say who.
Yeah.
And recredential, by the way, just means that you looked at their credentials. It doesn't mean that you've given them privileges. And yet I see that over and over again in minutes of governing body. Please make sure you have quite a bit of detail in there and follow through on any actions that the governing body has to take.
Can you elaborate on what should be attached? I know with the QAPI, I work on those a little bit more. And I know what to attach with those, but for the governing body, what should you attach and what should you not attach?
That's a really good question, and thank you for calling me on it. For example, you don't want to include or you don't want to attach copies of the quality improvement minutes because those are privileged information. They're not subject to subpoena. So you definitely don't. You want to summarize the actions at a very high level in the governing body minutes, but do not include copies of it. So I would think the things that you might be including or attaching would be like new policies that you've adopted. Sometimes you want to include your satisfaction survey results that come out of the satisfaction organizations. If you're using OAS caps, for example. I mean, you're right, though. I mean, I don't always see a lot of attachments. Sometimes you don't even see any attachments
depending
to it, depending upon what it is. But be very careful about what you attach to it. And make sure that they're totally relevant to your to the minutes that you're writing.
And as a surveyor, when you go in, what are you looking for to make sure that these standards are being met?
Yeah, that's a great question. And so the conditions for coverage and interpretive guidelines actually give us some examples of give surveyors an examples of what they should be asking for. So here's some examples. They want us to ask the ASC for information about its governing body. If there are questions about who constitutes the ASC's governing body, it may help to review the information the ASC reported as part of the 855B application. And identifying those individuals with ownership interest or managing control of the ASC. I think that's a little more difficult to identify, and you definitely, as I mentioned, you really want to go to the operating agreement, I think. Ask the ASC how frequently the governing body meets and what are the typical items in the meeting agendas. Ask, has the governing body delegated operational responsibility to a manager, and is that documented somewhere? They also suggest the surveyor asks for an organizational chart and look at that chart to determine who performs major functions such as like human resources management, medical staff credentialing and granting of privileges, management of surgical services, management of nursing services, management of pharmaceutical services, management of any laboratory you might have, management of the medical records, the infection control program, the QAPI program. And they're going to want to see those meeting minutes or any other evidence of the ASC's policies and procedures, making sure that they have been formally adopted by the governing body. And then really the surveyors are going to want to look at those minutes and delve into them deeply to make sure that there are there's an indication that the governing body is monitoring internal compliance with the policies and procedures and reassesses the ASC's policies on a regular example. For example, is there any evidence of data collected and submitted to the governing body related to any specific ASC policies? And then you also want to make sure that the meeting minutes have some evidence that the governing body is exercising ongoing oversight and accountability for the ASC's QAPI program. And so one of the first things that I do as a surveyor is when I go in and I look at a meeting minutes, if the first thing they talk about is money, I really start to wonder whether that governing body really is taking on the responsibility. Now, it could just be the order, but as a surveyor, kind of throw quality improvement in at the very beginning. That shows that that's the most important thing that you're looking at in those minutes. I mean, there's no requirement that it be done this way, but boy, when I'm reading those minutes, that's what I'm looking for, is some evidence that they really are focusing on quality improvement. And
even actually running through the meeting, I generally do see that the QAPI information is discussed first, because often, with some centers, once you get into the money, it can become very absorbing.
Yeah.
And, you want to make sure they're full attention, that they can really go through all of what I would consider more important.
That's right. Well, and of course, sometimes they invite the director of nursing or clinical people to the meeting in the beginning, and they don't necessarily want them there for the discussion of money, so they can step away. So it is a natural thing. So the conditions for coverage are very specific about the responsibilities of the governing body related to the QAPI program. Sue, why don't you mention, or why don't you cite what comes in 416.43E?
So the governing body must ensure the QAPI program, one, is defined, implemented, and maintained by the ASC, that it addresses the ASC's priorities, and that all improvements are evaluated for effectiveness, that it specifies data collection methods, frequency, and details, that it clearly establishes its expectations for safety, and that it adequately allocates sufficient staff, time, information systems, and training to implement the QAPI program.
And the interpretive guidelines go into much more detail. It says that you have to have an ongoing, successful QAPI program that requires the support and the direction of the ASC's leadership. And the regulation makes clear that CMS's expectation is that the ASC's governing body must assume responsibility for all aspects of the design and the implementation of every phase of the QAPI program. And the governing body must assure that the ASC's QAPI program is defined in writing, for example, in the minutes of a meeting where the governing body established the program, that it's actually implemented with written evidence of that implementation, as well as evidence of the knowledge of the program by the ASC staff, that it's implemented on an ongoing basis, not just, just before a survey, that employs quality and patient safety indicators that reflect appropriate prioritization, and that it describes in detail the indicator data that's going to be collected, how it's going to be collected, and how frequently it's going to be collected. And then it takes that data collected and analyzes it to really improve the ASC's performance, and then evaluates changes designed to improve the ASC's performance to determine whether they are effective, and takes appropriate actions to make further changes as necessary. And it has to be designed to establish clearly the governing body's expectations that patient safety is a priority, not only by the tracking of adverse events, but also by the program's processes for analyzing and making changes to ASC operations to prevent such future events. And also, they want to make sure that that the governing body has allocated sufficient resources. The ASC's governing body must allocate sufficient and qualified staff, including, if necessary, outside consultants, staff time, information systems, and training to support the program. Given the great variety in size and complexity among ASCs, the extent of the resources required can vary quite considerably depending upon the size and the scope of services that you're offering. However, the resources dedicated to the QAPI program must be commensurate with the ASC's overall scope and complexity. The ASC must also be able to identify in detail the resources that it dedicates to the QAPI program. So as a surveyor coming in, I'm going to have much higher expectations for a 10-room ASC, that's doing 10,000 procedures a year. Probably you're going to have a full-time quality improvement person, usually a nurse, often a nurse, that's in charge of that program. But, a smaller facility that's only open a couple days a week, maybe the director of nursing is full-time, but during those days that they're not in the operating room, they're doing the quality improvement. And it's so important that the owners understand that that nurse needs that time to go through this data to make sure that you're meeting the regulatory requirements, that they're getting the information to the governing body so the governing body can make those decisions. So what are the surveyors looking for when they're looking at the quality improvement programs? They're going to ask the ASC's leadership to explain how the governing body is involved in the QAPI program, which means that you're really going to want to go back to the minutes of the governing body to see a specific reference to the quality improvement program. Does the ASC's leadership display ready knowledge of the program's structure and activities? And if a contractor is used for some portions of the program, does the ASC's leadership monitor closely the activities of the contractor? Is there evidence of the governing body review of all elements of the quality improvement program? In other words, in the minutes. And then they're going to ask the ASC's leadership how it uses the program to actually improve performance. They're going to ask for evidence of changes made as a result of the quality improvement program activities. And then they're going to ask the ASC's leadership for documentation of the details of the resources that are dedicated. How much time is being dedicated to this? Who is working on it? What is their knowledge level? What things do they do on a daily, weekly, monthly basis? Is there evidence that these resources were actually made available as planned? For example, the surveyors are going to want to interview staff identified as having a role in the QAPI program to determine whether they actually perform those QAPI functions and what percentage of time is dedicated to it. So let's talk about governing body meetings again for a minute. First of all, I know the interpretive guidelines state that the governing body has to meet at least every year, once a year, but that is clearly not enough time to carry out the duties that we've just talked about. Really, it seems to me like we need to have quarterly meetings. That has always seemed to me to be more effective for that review, especially when it comes to things like quality improvement. Now, you might meet more frequently, because you have ongoing issues, maybe staffing issues, maybe, like during the pandemic, people were meeting weekly in some cases. But when it comes to the review of the quality improvement activities, you want to have enough time to gather that information. So quarterly is really a good time frame for that. The minutes should not be brief. They need to be more comprehensive and not bullet points. And they need to also be written by people that are familiar with it. I know back in the day, back in the 90s when I was doing, as an administrator, I had a secretary. I know it's hard to believe. I don't even think they use that term anymore, that I would record the meeting and then give her the tape of the meeting and she would write up the minutes. That's no longer done. Really, the administrator or the director of nursing or the quality improvement coordinator, depending upon the meeting we're talking about, is the person who's going to be writing up these minutes. And of course, the good news now is that we all use templates in the computer to be able to make sure that we've included all the elements that have to be included in those minutes. So your minutes are going to have to reflect the decisions of the governing body. They have to reflect the decisions that are actually made. They need to directly address the activities of the Quality Improvement Committee, and that any recommendations from the Quality Improvement Committee to the governing body have had an action taken. Now, other things that are going to be included in the governing body minutes are like discussion of the strategic plan and the goals and objectives, where you are on that. You're going to want to talk about legal issues if there are any. Of course, you're going to want to have a financial update. You're going to want to have a contract update. In other words, the governing body is going to want to review any of the contracts that were signed by the administration during the period since the last meeting. The governing body is also going to make sure that the administrator, director of nursing is reviewing all of their contracts for compliance with federal, state, and local regulations. You also want to review any new regulations to make sure that the policies have been updated as necessary. You want to prepare the governing body for changes that are coming. There needs to be some discussion of infection control. You want to review the status of facilities and equipment. And of course, you've got to have some discussion of the approval of privileges for healthcare providers that are working at your surgery center. As we mentioned before, you want to have an annual appointment of the different directors. And as we've kind of mentioned a few times, make sure that there's a discussion of the changes in the policies and procedures so that the governing body can approve them. So for more information, you may wish to listen to our full-day conference on the conditions for coverage, which had an extensive conversation about the governing body. This was recorded in 2023, but it is still up to date, and you can visit ASC-Central.com for more information. And as I mentioned earlier in this episode, we are rewriting a survey guide. It's called the Survey Guide, a guide to the ASC conditions for coverage and interpretive guidelines. It was last updated in 2020, and we do hope to have it published in a few months. Let's take a short break, and when we come back, we're going to talk about upcoming events.
In this segment, we provide an update on upcoming topics for the podcast, our upcoming virtual conferences, and upcoming speaking engagements for John and his staff, and other events in the ASC industry.
So the Joint Commission on Ambulatory Care Conference is November 5th through the 6th, 2025, at the Crowne Plaza Chicago O'Hare in Rosemont, Illinois. We do recommend that you keep track of the accreditation organization's programs coming up. I know HHHC's just occurred, I believe, And I believe there is another one coming up, but we don't have information on that yet.
ASCA 2025's Conference and Expo is April 30th to May 3rd, 2025 at the Gaylord Rockies Resort and Convention Center in Denver, Colorado.
And we are very excited to be there. I think we're going to have about 7 or 8 of our staff there. We do have a booth for the first time ever. So if you are a loyal, well, even if you're not a loyal listener, stop by the booth and get some of our freebies, as well as more information about the services that we offer. Yeah. We're very excited. This is the first time, as I said, that we've ever done a booth, and I hope to have a lot of fun with it. At ASCA, right. And I am speaking at the conference on financial management. And the Gulf States Conference, which is Alabama, Louisiana, and Mississippi ASC Association's annual event, is June 11th through the 13th, 2025, at the Ritz-Carlton, New Orleans.
The Florida Society of Ambulatory Surgical Centers annual conference trade show is July 23rd through the 25th and at the Hilton, Orlando.
The New York State Ambulatory Surgery Center Association's annual conference is going to be held October 6th through the 8th at the Desmond in Albany, New York. And I'll be speaking at the conference, and we'll do a special episode there. We always have a major presence at the New York State Association meeting, mainly because I founded the organization some 30 years ago and still a board member with them. But also because we have so many centers in New York, and that we actually tend to have our annual meeting of our New York clients there at that same time, and we do the pre-conference. So please, if you have an opportunity, make sure you go out to the New York State Association Conference in October.
The Oregon ASC Association's annual conference will be October 9th and 10th. We'll have more information to follow, and John will be speaking at that conference and plans to do a special episode there too.
I'm very excited. That'll be the first time that I'm going to Oregon to their association meeting. And the Washington Ambulatory Surgery Center Association's 2025 annual education conference and trade show is November 6th and 7th. 2025 at the Tulalip Resort and Spa in Tulalip, Washington. And I'll be speaking at the conference, and again, we'll be doing a special episode just like we did last year. I love that place. I know you're not going to be able to go with me, Sue, this time, but it is a great opportunity to speak in a great organization, like all of our state associations.
And the Colorado ASC Association's conference will be held on November 13th and 14th. Well, again, we have more information to follow. John will be speaking, and we'll do a special episode there. Boy, you're going to have a busy
October and November,
and early winter.
Well, and again, Colorado is a new conference for me, and the person who organizes the Oregon and Colorado associations, he and I are long-term friends, and I'm very much looking forward to working with him on these two conferences. So remember also that on-demand versions of the ASC Director of Nursing, the ASC Administrator, and the ASC Business Office Manager's bootcamps are available on our sister website at ASC-Central.com. And we do want to remind everyone to become a patron member of the podcast. We have over 300 patron members at this point. And don't miss out on the benefits of joining the patron member program, which is more information is available at ASC-Central.com. This comprehensive membership platform is your go-to resource for all aspects of ASC regulatory and accreditation, compliance, operations, and financial management. It's designed with the busy schedules of administrators, nurse managers, and business office managers in mind. By becoming a member, you gain access to our regular, usually weekly Zoom sessions where you can engage with other patrons and our podcast team. We usually have at least 2 surveyors, sometimes as many as 4 surveyors on these weekly, as I said, often weekly drop-in sessions. But that's just the beginning. Your membership unlocks a wide range of resources, including access to virtual conferences that have been recorded in the past, such as our credentialing conference and our conditions for coverage conference. You also find valuable tools like sample policies, procedures, forms, and our highly regarded fire and disaster drill kits. Your support helps us to maintain and grow the podcast, covering essential costs such as research, travel, equipment, and production. To learn more and to become a member, visit ASC-Central.com.
Thank you for tuning into this episode of the ASC Podcast with John Goehle. We hope you found the discussion insightful. If you did, please share it with your colleagues in the ASC community and be sure to subscribe so you never miss an episode. We appreciate your feedback and your suggestions for future topics. Please reach out anytime at comments@ascpodcast.com.
And a special thank you goes out to our incredible team here, the sound editor, Susan Cronkite, Executive producer John Goehle and our committed research team of Susan Cronkite, Jenna Alvarez, Judy D'Ambrosio, Mike D'Ambrosio, Zach Calritis, Jim Masters, Amy Cronkite, Lori Rodericks, Kathy Foti, Donna Macchio, and Christina Norman. Their hard work makes this podcast possible. Our theme music is by Media Sushi and Mike Noah, and the ASC Podcast with John Goehle is hosted on Podbean and is available on all major podcast platforms. Thanks for listening, and we'll see you in our next episode.
This episode of the ASC Podcast with John Goehle is sponsored by Surgical Information Systems, RFX Solutions, MedServ, and Ambulatory Healthcare Strategies. Surgical Information Systems provides cutting-edge information solutions for surgery providers. RFX Solutions is your all-in-one healthcare regulatory compliance software. MedServ, which offers the only digital narcotics cabinet specifically designed and priced for surgery centers, helping develop standardized processes and compliance, eliminate paper logs, and prevent drug diversion. And Ambulatory Healthcare Strategies is the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For more information about our sponsors, visit our website at ascpodcast.com. This podcast is an educational and operational tool and is not intended to be a comprehensive resource for all rules, regulations, and standards that an ambulatory surgery center must meet. The advice provided should not be considered as, nor does it constitute legal advice or opinion. When reviewing specific situations involving legal and regulatory issues, attorneys and other professionals should be consulted. This has been a production of Eden Group Development. All rights are reserved. If you're interested in advertising or sponsoring the ASC Podcast with John Goehle, please email us at info@ascpodcast.com. We would love to hear your questions and comments. Please email us at comments@ascpodcast.com.